And one of the things that Jack has done, if you've been on NAC with you, and I know many of you who have not will certainly be on soon, is a lot of information about the, what's it called, the Affordable Care Act. And there's been uproar, and we alluded to it yesterday in the talk by Daryl. And so I asked Jack if he would just give us an overview of Obamacare and all of the things and the ramifications for us in our senior citizen category. So, Jack, please.
Thank you, Ruth. And I can say that for Judy Moss and Mariana Caldwell and I, 3 days of being on East Coast time and getting up like 3 in the morning or something is beginning to wear. So if I seem a little testy and irritable, that's that may be part of the explanation. This came up because we did an article in the Lifeline on the new health care law, and Ruth felt that raised a number of questions among her fellow residents at Stonington, and she thought that it'd be nice to have a Q&A session where they could ask their questions. How many of you live here at Stonington, at Stone Ridge? Okay, maybe a third. What percentage of the total residents are there? Do your fellow residents?
It depends on the day, but now they're not that too terribly many
Okay.
from Stonebridge.
Anyway, so she asked me to talk about Obamacare, which is a nickname that it started out, I guess, as a kind of pejorative, but it's become attached to the law, and he's claimed it himself, so I guess now it's acceptable. But the official name is the Patient Protection and Affordable Care Act of 2010. And actually, there are 2 enactments that make up the full program that's usually referred to as the Affordable Care Act. The second enactment being the Health Care and Education Reconciliation Act, which is also 2010. So those 2 laws were put through that year. Now, the law itself is very complex. Here you see the 10 titles that make up the law. You don't have to read that if your eyesight is weakening as mine is. Don't fret about it too much. But it just suffices to say that it is complex, and the law also left the details to be resolved later. So a lot of the details were to be resolved by regulation, and we've already seen how certain parts of the law, I don't think we do. Do we need it totally dark? I can't see anyone. Are you out there?
We're out there, guys. You can now see the screen with the lights out.
All right. But anyway, the law, aspects of the law have already been delayed. Now, you say, well, how can, if it's a law, how can it just be delayed by some little act of the President? I don't fully understand that myself. I believe that what the President has chosen to do is to say, I'm the Chief Enforcement Officer of the government, and there are certain laws that I will enforce. I am my Attorney General, and there are other laws that we will not enforce. So I believe when they say that the effective date is delayed for a year or that sort of thing, that really means that he's choosing not to enforce the law as it was enacted. But that part is not clear to me. Anyway, the Title I is full of high-sounding phrases, so if you read that, you'll find out that the insurance companies were limiting benefits and doing this and that evil act, and now they're not allowed to do those evil acts anymore. The second title covers the Medicaid programs, and I think you all know that the states were concerned about the additional cost that the states are expected to incur under that aspect of the law, but the states that have embraced it seem to be handling it pretty well. The next area had to do with improving the quality and efficiency, and the main aspect there are these accountable care organizations, which Daryl Patoska talked about yesterday. And the one part of that that may be of interest to you is that if a local hospital were to enter into an accountable care organization with a skilled nursing center, so that when people are discharged from the hospital, they go to a skilled nursing center that is affiliated with the hospital. There might be a question about whether you would be able to come back to the nursing center in your own CCRC. Now, we do have a law that NACRA led the fight for, particularly Milt Brummer, who got it in working with Barbara Milkowski, is that her name? I forget, but the Maryland senator, which is the Right to Return Home Act, which says that if you live in a CCRC, even if you're in a managed care program, you have the right to return to your own CCRC. It's unclear whether we retain that right under this new law. The new law may have preempted that, and it may be that if you're hospitalized, you would be returned to a facility other than your home facility if they offer a lower cost of care. The prevention of chronic disease and improving public health goes to a lot of things like mammograms, that sort of thing, and that's all possible. The healthcare workforce provides scholarships to train workers and doctors and to improve things. Transparency speaks for itself. Improving access to innovative medical therapies, I think, is mainly restrictions on the pharmacy industry. There are two industries that were under heavy criticism. Here, one is the insurance industry, and the other is the pharmaceutical industry, and this law responds to that kind of criticism. This Title VIII, the Community Living Assistance Services and Supports Act, the CLASS Act, was a program under which people would voluntarily have paid into a program for 5 years, and if after they paid in for 5 years, they would have been eligible to receive a cash payment benefit if they needed long-term care under certain specified circumstances. It provided that the program was to be self-supporting, and yet it was to have subsidized rates for lower-income people. So it meant that more affluent people would have voluntarily paid more than they would have paid in the private system to provide coverage to subsidize the poorer people. And it was found that that was unworkable, and the law was repealed on a bipartisan basis. However, the reason why it was included in this law was because that 5-year pay-in. I think you all know that Congress doesn't handle accounting in the way that a private enterprise would handle accounting on an accrual basis. They do cash balance scoring over a 10-year period. So receiving 5 years of premiums before benefits were paid meant that there was a big cash inflow, and that helped to balance the new benefits that are provided under the law. Now that that prop has been repealed, clearly there's an imbalance, but Congress has not gone back and recomputed the scoring, so that's just an open item. There are some revenue provisions in the law, and finally, there's a technical thing here, the reauthors of the Indian Healthcare Improvement Act. I have no idea what that is, but I think that's just thrown in here. Probably something for people who run gambling establishments. This shows how opinion has gone on the law. The top line there, which is red, if the color's coming out, are people who viewed the enactment unfavorably. And that's about half the people view it unfavorably. I'm not sure what that means. I mean, I think this thing is here to stay, and we ought to embrace it and make it work. The green are the favorables, and the gray, I guess it's gray, looks a little purple up there. But anyway, that's the don't knows. And it looks like as the don't knows are going down, as people become more familiar with it, the favorable seems to be increasing. And I think this split is simply indicative of the polarization in our country, which is unfortunate and hurting us as a nation. But you want to know how the whole law affects you. We've talked about one aspect already. We hope that we still have the right to come back to our home CCRC if we need rehab or something like that. Here are some of the answers. If you have straight government Medicare, you're probably not going to be affected much, although bringing new demand into the system without increasing the supply proportionately, and that's a judgment whether that's true or not, because they have those education things and all, they're trying to do it, is apt to increase costs, at least in the short run, although there is some promise from the accountable care organizations, although there's also some contrary information that hospitals are gaming that program, so it's not clear how this is going to go. But if you have straight Medicare, your benefits are relatively unchanged. If you have a Medicare Advantage plan, and many of you may not know, that means if you receive all your benefits through an HMO, in my case it's Kaiser, I don't think you have Kaiser out here, so I don't know what you might have in the way of a HMO type program, then your costs are directly increased. And that's because the administration decided that those plans, those managed care plans, had been getting a subsidy from the government. The subsidy came about because they had promised when the program was instituted that by managing it they'd be able to reduce costs, so they were going to receive the money from the Medicare administration that would go for straight Medicare, and then if they could reduce the cost, there'd be a gain in there, and they used that gain to provide additional benefits. Well, they decided that the gain that was due was really a subsidy, and so they took that away. So the part of the balancing of the cost of the new program was to reduce the payments to seniors under these Medicare Advantage plans, and you may have seen very large increases in your copays. My copay for Kaiser, for example, on a lab, and believe me, we have a lot of labs, went up from $20 to $40 each time. The hospital deductible went up from something like $1,000 to $3,500, that sort of thing. That's a direct result of this law. If you have hospitalization, you may be classed as an observation patient, and that may dramatically impact your cost. Now, I'm sure you've heard a little bit about this. Let me just quickly tell you what it is. The hospitals are penalized if they discharge somebody and then they're readmitted. So they're under pressure to get you in and out of the hospital quickly, but if they discharge you and you come back, they get a penalty. So one of the things that they do with the government system, we all do it on our income tax, you game the system as best you can, to try to minimize your impact. So what they did was to say, well, if we're going to be penalized for readmissions, we won't admit them in the first place. We'll just watch them. And so they call it an observation. Now that affects you. If you have straight Medicare, you have to have been in the hospital 3 days before Medicare gives you 100 days payment in the skilled nursing facility. Now that you're not hospitalized, you pay that 100 days in the skilled nursing facility. You're on your own unless you have a type A contract, then your provider's taking that hit. So that's one change that isn't in the law directly, but the incentive, the intent was to improve the efficiency of the process, but the effect has been to change the classification of some hospitalizations. The prescription donut hole has been eliminated, and I think we all are pleased with that. I don't know how many of you have fallen into the donut hole. I think you have to have some fairly expensive medications, but that's been eliminated, and that's a very positive step. And the law mandates a subsidy for older Americans by younger Americans. And I'll explain that. The cost on an actuarial basis, the health care cost for people over, say, age 70 is roughly 7 times the cost for a person in their 20s. Costs of medical care go up toward the end of life. It goes up exponentially. The AARP, as the price for its support of this law, mandated that the premiums for older people could be no more than 3 times the premiums for younger people. Well, now, turn that around. If you're trying to run a business and you have to cover your costs, that means that the costs for those younger people have to be at least 1/3 of the cost of the oldest people. So, for the younger people, that's not a very good deal. And you may have heard, we need to have a lot of young people in the program to make it average out. We need those young people in there to subsidize the old people, or the numbers won't work. That's the problem. And so that's a direct subsidy by the young people of America for the older people. Whether they can afford it better, then, because we're the greatest generation, right? We've got all sorts of, but anyway, that's another question. That was a political decision. The future effects of the law are less clear. Will there be enough providers to meet the increased demand? We're bringing new people into the system. Not bringing all of them in, but we're bringing many, many new people. We've heard numbers, I've heard as high as 15 million, 7 million coming into the government exchanges and more through other programs. Excuse me. Time changes, catching up with my voice. So this raises the question, will waiting times at doctors' offices or elsewhere increase? I don't think we know that right now. I do know that in our area, there are beginning to be waits for things like bypass surgery, where there were no waits before. I don't attribute that directly to this law. I think it's just a trend in the way things have been trending for some time. Will employers drop retiree health care coverage in reliance on the government program? Now, some of you may have the good fortune to have continuing coverage from your employer. Some of you may already have heard that your employers are dropping that coverage or going, oh, thank you. Is that very good? Let me try it. Sweet elixir. I feed you with living water, but sometimes real water is really nice. But anyway, so there's a question whether that coverage, how that will be impacted. You know, and that goes along with a whole lot of things. You've heard the thing about employers who are choosing to have part-time employees to escape having to incur the cost of the law, that sort of thing. And that's part of, I think, why those sections of the law got deferred. Will the individual mandate hold to prevent people from gaming the system to run up costs? One of the big criticisms was that before you had to present your health condition to qualify for insurance, and your premium was adjusted to reflect your health condition. This law eliminates that, but it does it on the premise that everybody will be included. If everybody's included, then you have a predictable mix of healthy people and less healthy people, and you can cover that. If the people game that system so that the healthy people avoid paying into the system, the healthy young people who we need to subsidize as old folks avoid coming into the system, if that were to eventuate, then we would have difficulty, and we're not sure how that individual mandate may work out. There are penalties, but some people talk about maybe paying the penalty rather than, so we're hoping that works. That's a critical piece of the system, and it went to the Supreme Court, as I think you know. Will the integration of care services mean that CCRC residents, well, we already talked about it, will no longer be able to return to their own care center after a hospitalization? Will private coverage now give way to a government program? The health insurance exchanges are set up to allow private coverage. In the generic talk that you hear the pundits use, they generally call those insurance companies, but it includes programs like Kaiser and Blue Cross. And Blue Cross and Kaiser were not traditional insurance companies. They're not regulated in the same way that insurance companies are, and they don't have quite the same level of integrity but they are private coverage. The risk is that if the program doesn't fit together just right, that they may lose profitability. The profit margin in health insurance over the term of my career has been roughly 2% of premium, so you don't have a lot of margin in it. Now, a lot went out to pay salespeople. Presumably, you don't have to pay them as much, but the salespeople are a powerful lobby. They've been lobbying. They still want to get a piece of the action. So we don't know how all those pieces are going to play out. But if the private coverage were to fall away, then we'd be into a single-payer premium program without it having any further discussion of the question. The politics have been dysfunctional. The health care reform laws are seen generally as unilaterally the products of a single party, the Democrats. I think that's unfortunate. I'm ashamed that the Republicans didn't come to the table, haven't come to the table, continue to talk about repeal. That just is unhelpful. It's even more associated with the president, and that's resulted in being called Obamacare. And it started out as a pejorative, but I think now it's beginning to be viewed positively as something that may prove to be good for his administration, despite the negativity. The Republicans have demonized the bill in order to rouse their support base. And that's a very unfortunate demagogic approach to our national welfare. You know, we're all in a common society, and that just seems like a misuse of the political process. The Democrats demonized the insurance industry, and to a lesser degree the pharmaceutical industry, in order to rouse their base. And that was equally unhelpful and equally demagogic. And eventually, after the difficulties with the initiation, they had to bring in insurance experts to try to make the thing work. And I'm hopeful that now the government officials are working together with the industry to make this thing work. Lost in all this is the public good and the constructive development of an approach to health care that might address the problems of the current system. And the problems are high cost. Our cost is now roughly 18% of our gross domestic product. That means nearly 1 in 5 of every American is working to take care of the health of the other 4. That contrasts with 13% of gross domestic product in countries like Switzerland and the Netherlands, which are next in line, and or Germany, which is a little lower, but has a system very similar to ours with private health insurance, but mandated universal coverage. The German system is sort of the way we do with automobile insurance, where you're required to have it. So we have this high cost. We lack universality of access. We still are excluding people who are in this country illegally. And like it or not, they're here. And when they get sick, and they get diseases that are contagious, and we all know that the antibiotic-resistant infections are becoming a major source of mortality among people in our age group, these people can't go get treated for that, so they may, when they come in here to help out in the facility, they may be bringing those illnesses right into our CCRCs. They're not in the system, so that they have nowhere to go for treatment. Maybe it's not appropriate. They shouldn't have come in the way they did, but they're here. And we've had, if you look at the data, the efficacy, the United States system is very good if you're very sick and very weak for routine things. Personal perceptions and opinions tend to follow for one's own interests and personal political leanings, and I'm going to guess that's true in this room. I heard somebody yesterday who talked about Republicans. She said, they. So I knew where she was coming from. I heard another person who was talking about the Democrats. They want. I'm never going to vote for him again. And so we all have our leanings. Many people favor single payer and would be happy to have a government monopoly system like we have for the Social Security system. And they just want to believe that government is benign and will do a good job. Many people believe that other countries' healthcare programs are more successful than that of the U.S. Canada, the UK, France, Germany, or Switzerland. I can tell you that when you get into the depths of what's happening in these other countries, you find out they're having their own set of struggles with their programs, and it's best to inform yourself on that before you conclude that you'd really like the UK system or the Swiss system or the French system, which is a particularly interesting one. Some people oppose the hand of government, regardless whether that hand is positive or not. Strong personal leanings encourage, as we've already said, demagogic political posturing and impede more deliberative responses to the healthcare challenge. This is a real problem. This is our #1 national economic challenge. When we're spending 18% of our productive capacity on healthcare, we cannot compete in the global market with other nations. It's that simple. We're not competitive. And this is a huge, huge challenge. I think you all know that the politics of this thing continues. And on Thursday it was announced that Kathleen Sebelius would be stepping down. So she's to take the hit for the criticism. I'm not sure that the criticism has been fair. You know, whenever you implement a massive new insurance product, you have launch problems, and you scurry around to straighten them out. I know, I'm looking back there at Joe Walton, I know he's been there and done that, and Milt Birdsall's been there and done that. But those of us who have been in the insurance industry know that nothing ever goes smoothly, particularly in the systems area when you roll it out. So I think it's unfair to be critical of that. I think she was probably doing the best she can. But there was a certain irony, because yesterday the president had her in the Rose Garden to honor her, just as we honored Ruth here in her home community. And she got up to give her remarks, and she's reading her remarks from a paper. I guess even at her level, they don't speak entirely extemporaneously. She's reading her remarks, and a page was missing. And she had to stop and say, oh my goodness, a page is missing. So that brings us to questions. Let's start with Joe Walton behind you, Dan, and then I'll come to you because he's in the back.
In our community, more than a few residents that are enrolled in the Medicare Advantage program are saying that they no longer have access to their physician who's been taken out of the insurance company's network. And it's one way some feel that insurance companies manage their costs. They exclude doctors that generate a lot of claims. I wonder if you might comment on that, Jack.
Well, I don't think that they exclude them. The insurance companies got into trouble because they were the only entity in the whole system that was seeking to control the costs. The costs have just mushroomed out of control. The Congress tried to do something by putting in an index to doctors' fees called the sustainable growth rate, and then that became an annual football. Every year, Congress enacts a new law to revoke its prior enactment of this sustainable growth rate, but they require that the government actuaries and economists and projections include that growth rate as though it were real. And they call this the doc fix. So what insurance companies have done, and I don't know whether it's truly an insurance company or an HMO, which is a little different, but what they have done is to say, this is the level of cost that we believe is appropriate for the service provider. And doctors say, hey, I can do better than that. I won't take your deal. And I'm out of your system. So now somebody who's relying on that program has lost a doctor because the doctor said, I'll do better on my own, or I'm going to retire. I ain't going to take it. I'm used to earning $800,000 a year, and I'm not going to stop now. So, you know, that's a challenge. I don't know how you address it.
Well, some of the physicians in Connecticut have appealed to the insurance department and to the insurance company so that they can get back in their networks. they feel that they've been unfairly excluded. But
Well,
you know,
I'll tell you.
whatever the answer is that the fact is it appears to be a significant factor for those in Medicare Advantage programs where you no longer have access to a good physician. You continue to be covered, but you have to go to another doctor to get coverage that you had before the changes in the networks.
Well, I don't know that it's exclusively there, but if you're in a managed care system, they're seeking to give you better care at lower cost. Now, I'm also involved with the audit committee of our local hospital, and we just hired a kind of specialist that I'm told that you must have. This guy was kind of a squirrely guy. I mean, he could barely speak when he addressed us. We're paying him $700,000 a year. We have to guarantee his income. He bills patients, but the hospital guarantees the income. He won't affiliate with your hospital unless you guarantee his income. $700,000 a year because of this highly complex specialty. He's a cardiac electrophysiologist. So what has happened is, since 1965, the law has favored specialization, and the greater the degree of specialization, you know, if you're an ophthalmologist are the highest paid physicians in the system, but retinologists get even more, because that's more specialist than just doing the whole eye. If you just concentrate on the retina, they're the highest paid of all, because that's the way the structure, the fee reimbursement structure has been put together by the wise minds doing the job. So I think that's just built into the way we've developed our program in this country. Dan, you had a question, and then Walt.
Jack, some of my neighbors have gotten caught in this business of being put in the hospital for observation. They've come home not realizing they weren't really in the hospital, and with all the economic fallout that you've described. Is there any way that we can refuse to go to the hospital if we're not going to? I mean, they only found out they were under observation after they came home. Is there any way we can refuse to go to the hospital if we're not admitted, or is there any remedy that we can have?
Well, you've got to realize that in the hospital business, you have to push reimbursement coding as close to the edge of fraud as you can without being found to have been fraudulent. Because over half of your dependence is on the reimbursement rates set by the Centers for Medicare and Medicaid. And the private payers, most of them, follow CMS because CMS is so huge. So that determines the reimbursement rates. And part of that is whether somebody is in for observation or not. And they can classify it as observation if they say the physician hasn't completed his write-up of the case yet. And so that might be a week that you're in the hospital. You're in the hospital because you need to be in the hospital. You look around and it looks like a room and a bed. But the hospitals are very impacted by the retrospective payment reductions if they have readmission. So they're very reluctant to classify something as an inpatient admission. That's just inherent. You must be gaming the system. And this is going to be a huge thing now with the introduction of the ICD-10 classification structure, which is going to increase the number of disease classifications that are dependent on the hospital physicians who are not employees of the hospital to write up these things. Are going from around 18,000 disease classifications to 70,000. And the coders in the hospital have to be masters of this new system in order for you to get the reimbursement that you need to operate that hospital on a profitable basis. And if you look at your local hospital, you'll see they're not highly profitable. The problem is we have a surfeit of hospitals in the country. Everybody wants a first-class hospital down the street from them. That's a problem. Walt and then Joseph.
Yeah. Statement and then a question.
Okay.
On the hospitals, we had the CEO of our local hospital come talk to us last year, and he told us that their hospital specifically, and it was typical of many hospitals, gets about full payment for their services from only about 25% of the people they admit. The rest either don't pay at all or pay only a fraction of what the bill really is. And they've got to make things, you know, they've got to meet their bottom line even so when they don't get paid. The question, no, I've forgotten what my question was. So I'll sit down and come back.
Well, that was a good statement. Joseph and then Gene.
Just piggybacking on this.
Why don't you introduce yourself, Joseph?
I'm Joseph Cumming, and I'm his son, and I'm not a CCRC resident. Yes. So if your doctor says, I'd like to keep you here for a few days for observation, can you say, what will happen if you say, either admit me or no?
That's right.
I want either a hospital administrator to come here and tell me I'm being admitted, or no, I won't stay. What will be the outcome of that?
Well, having recently gone through an incident in which 3 doctors said, get to a hospital just as quick as you can because we think you might be dead within 72 hours. After I heard that from the 3rd doctor, I was fairly alarmed. Unfortunately, it turned out not to be necrotizing fasciitis for the doctors in the audience, but they thought it would be. And if you want to have fun, look up necrotizing fasciitis. It's just as awful as it sounds. But anyway, I can assure you that when you're lying flat on your back, hoping to survive, you're not in an angry mode to argue with the hospital. These people come in, you never have met them. They're hospitalists. That's a new thing because regular doctors don't like to work after hours. So now we've got hospitalists who take over your care. So you've got people coming in, they say hello, and you're nice to them because you're polite, and you get a bill for $1,000, and you say, what was that for? And they like to get paid. So, you know, you're not really in a position to manage your own. The burden shouldn't fall on the patient. That's the long and the short of it. The burden shouldn't fall on the patient. We ought to have a system that simply works. And we're not there yet.
Jack.
Anyway, Gene, and then Beth, and then Bob. Can you wait, Bob? Can you stay? I know Bob has a little bit of attention deficit disorder. If you can hold it, I'm trying to call on people in turn as they raise their hand. Gene, go ahead.
Yeah, just a couple of facts I'd like to get straightened. The sustainable growth rate, was that a piece of legislation?
Yes.
And when was this enacted?
Oh, probably 1992.
Okay.
I think it's been, I believe it's been revoked every year since.
It applies to all, it applies to insurance companies as well as Medicare?
No, it applies to physicians. The main job of the American Medical Association is to have a lobbying office in Washington to lobby Congress to enact every year the doc fix. And that's, the doctors write big checks to support that. The AMA is no longer really, except to a minor degree, an organization that maintains professional standards. It's primarily a lobbying organization to maintain doctors' incomes.
So doctors are obliged to charge the rates that are on the sustainable growth rate charge?
No, they're not. They can charge anything they want. They just won't get paid by CMS.
They won't get paid by
Medicare.
Medicare. CMS is the Centers for Medicare and Medicaid. CMS, Centers for Medicare and Medicaid, is that we have our medical system is a planned economy. Just like, you know, in any socialist economy where you have central planners who plan the economy. And the planners are in Baltimore, and it's called the Centers for Medicare and Medicaid. They plan the reimbursement rates. They establish the rules for accountable care organizations. They decide who qualifies as, and all of that planning is done centrally in Baltimore.
Okay, so this explains why on our Medicare statements, we have what the doctor charged, what Medicare allowed, and we are only paying 20% of what Medicare allows, the copay.
Yeah, well, it gets a lot more complicated. I don't want to go, I mean, hospitals, to play this game, have a thing called a charge master. The charge master is supposedly the list price for the services that a hospital provides. In practice, the hospital might accept 18% of the charge master prices. But if you're a private pay person, if you don't have insurance and you come in on your own, then you're going to pay 5 or 6 times what the insurance company would pay because you're going to pay the charge master. Now you say, why is that? Because under the CMS program, the planned program by which hospitals are reimbursed, they get a higher reimbursement rate if they have a heavy charitable care burden, and they're allowed to value their charitable care burden on the basis of this artificial charge master.
Okay, well, that's, yeah, I was...
The system is so complicated that you'll never get your head around it.
A second question I have, and that is, you said under the Affordable Care Act, younger people are going to be heavily subsidizing older people. Have they been doing that all along under Medicare?
No, that was, the AARP included that in this law as the price of its support of the law. It was just enacted into law. It's an artificial price constraint.
So younger people do not pay Medicare premiums?
Well, they do. And now we're all in one program, right? We're all going to have this affordable care program. So the prices.
Since 1955 or whenever Medicare was enacted, when do people start paying Medicare premiums? Is that coming along with your Social Security?
Well, now you've got to. Okay. As part of your Social Security tax, you pay a hospital insurance tax. That is called Medicare Part A.
But younger people pay that. If you're 30 years old, you're paying.
Everybody pays that, yes.
Okay.
And that money goes in that I guess it's really a direct subsidy to the old people, the way it's worked now, because it's on a pay-as-you-go basis. It wouldn't have to be, but that's the way it is. So maybe the answer is yes, there has been some of that.
Yeah.
But this makes it explicit that they pay 1/3 of what the older people pay, or even though their cost is only 14%.
But they've been doing this all along. There's no change, really, under the...
Well, they could, before, a lot of them opted out, and many of them were in private programs. The private programs weren't regulated in this way before.
Well, you can't opt out if you're in Social Security. If you're paying Social Security, you're paying Medicare.
Okay, well, let's talk privately about it afterwards. Beth?
Yeah, I want to go back to the, excuse my voice.
I have the same problem. You want some water? My water?
The observation admittance business. This emphasizes that nobody should be sent by ambulance to the hospital without an advocate with them. And this was something we talked about when we first went into our community. And we had a program where we had volunteers who would go with somebody and be the temporary advocate until a family member arrived. That program has sort of fizzled, and lots of people go to the hospital and nobody's with them. Now we really need to be sure that somebody is with them. The community doesn't send a CNA or anybody with them. So to protect them. Otherwise, they're all going to end up in observation, and our nursing center is going to have a problem with all the extra costs of people coming back without having Medicare coverage.
I think the answer to that is we ought to reform the system so that you don't need to take a lawyer with you when you go to the hospital. So the problem is one that we've been familiar with in the history of the world, that planned systems have not typically worked well because planners are not omniscient.
Well,
And you've got to
always
remember,
find a loophole. They'll always
you've got to
find
remember
one.
that macroeconomists are really politicians operating under the guise of intellectual propriety, of intellectual integrity. But
Is
really-
there any pressure that NACRA and Leading Age can put on Congress or whomever to correct this, or to
Well,
make them tell the patient, you are under observation. We're putting you in a hospital bed, but you're still under observation. We had
yeah, but we don't want to just do one piece of the puzzle. But
all right, but we're not going to.
we don't now have protection for long-term care. The major looming health challenge in this country is the absence of an effective long-term care program unless you spend down yourself into poverty and go on, become a ward of the state under the Medicaid.
Acute care.
But let me just finish my answer. And so, in trying to address that, as your director of research, I've been working on a paper, it's in the works, these things are not simple to write, to say, how would you cover long-term care? Well, you can only cover long-term care if we reform the healthcare system in toto, because the money is gone, right? 18% of GDP, it's out the door. It's going out, so you gotta look where the money's going, you gotta follow the money, and then say, how can we create incentives to get it going in the right direction, because the heavy hand from above hasn't been working well. You push it here and it pops out there. And so we're trying to develop something which eventually will be exposed to the NACRA group, starting with the board, and then possibly that might be something where we could go. NACRA is the only entity in the country that has priced out what the cost of long-term care is in the country. You won't find a financial estimate anywhere except in NACRA, and it was published in the most recent Lifeline. So it's all part of this overall thing. You've got to look at the whole puzzle. More than half of the cost in our system goes for hospitals and doctors. And since our cost is roughly double that of other countries, you can't possibly get down to a competitive cost, which would be half of what it's costing us today, without cutting those people who are contributing half the cost. And neither of them want to be gouged, and they've got very powerful lobbying interests, and our government no longer is serving the general interests, it's serving partisan interests. So that's a problem that we've got to be able to address. Whether NACRA can do it or not, I don't know. For NACRA, a little organization like NACRA, to have clout, we'd have to get Washington to agree to look at matters on their merits instead of on the basis of short-term advantage. That's a tall order. Walt remembers his question, but Bob is waiting patiently. Let me jump to Bob and then back. Bob, you've been waiting
Well,
patiently.
Beth and I are on the same page, and I just came from Presbyterian Village North in Dallas. My colleague, the Presbyterian minister there, is the chaplain. She or her other chaplain attend every resident who is taken to the hospital to do exactly what you're talking about. It's a little easier when you have a paid person in their job description to do that. But my question is, Jack Matheson talked about this, and I'm very grateful to him for this magnificent geriatric physician on the staff of Leading Age. Could not that person partner with NACRA, and let's get a hospital administrator and a geriatric social worker, create a panel and have a Lifeline expose of a resident advocate attending people who go to the hospital, and say, while we can't do what Jack wants to reform the system, which we'd all like to see happen, in the meantime, if somebody in this room has to go out, who's going with them to protect them from being victimized by sitting around 3 days under observation and no benefits, and they're discharged back to skilled nursing, and there's no coverage.
Well, two thoughts. One, if we put the cost of the chaplains into the system, maybe we're up to 20%. I don't know. But I think that's a very positive thing. You're proposing a panel that we would do with leading age. We would put in a panel presentation to them, which I thought was pretty reasonable. We have a senior provider executive and some senior people, and we're not hearing anything from leading age. I suspect that if we really want to do something, Bob, we're on our own. Now let's go Walt, and then Arnie, okay. So Walt, Arnie, Jack, Joseph, and then John.
A year ago, I was hearing a number of statements in the news and from hospitals, doctors, about the fact that a significant portion of the cost of for hospitalization, medicines, and doctors was due to litigation. This year, there's been this big silence. I haven't heard that very much at all. Is there anything in here that relates to tort reform? Or correct that?
Well, we ought to make lawyers accountable for bringing false lawsuits. Most countries do that, so that if a lawyer brings a lawsuit that's ill-founded and he fails, he pays the cost of the litigation. We don't have that in this country. That's a reform that would take care of a lot of that right off the bat. That accounts for about 3% of the cost in the system, and we've got a problem that's 50%. So we've got, you know, if we got rid of all of that, part of the problem is that the physicians use peer review to view whether they're practicing competently or incompetently. And peer review has not worked well because physicians don't censor other physicians. You know, there's a brotherhood of laborers there. And so the only accountability really comes from the lawyers who hold them accountable. Now, I encountered this recently with this incident that I was telling you about. After they had operated, they had me go in every day for what they call packing. How many of you know what packing is? Have you ever had packing? Hardly anybody. Okay. They take something that looks like a shoelace and ram it into your wound, and it hurts like hell. And they say, this is to keep the wound from healing from the outside in, which would create an abscess in the body. They want it to go this way. So now you've got this shoelace there, which is a wick to bring infection into your body. And this didn't make a whole lot of sense, and I was in pain every day when they do this thing. So I went on the internet to find out, and I found out, gosh, they did a study, and for surgery, they had packing. The surgery had to be redone because it had failed 87% of the time. But if you don't pack it, the failure rate's only 25% of the time. So I went to the doctor and said, hey, do we really need to do this packing thing? And he said, oh, well, you're right, no more packing. So miraculously then, I healed very rapidly after that, and they're no longer jamming in the wound and opening it up every day. So now, does that mean that physicians know what they're doing, or don't they know what they're doing? I don't think we have standards of practice. The AMA, which could be spending its energy developing standards of practice that would be best practice, is spending its time lobbying Congress to be sure that doctors' incomes are maintained. And that presents us with a problem. Jack Matheson.
Just an observation, when I received a pacemaker, I later received the bill from Sibley Memorial Hospital in Washington, D.C., where every department submitted their bill. It came to $27,600 with 2 nights in the hospital. $27,600 for a pacemaker. to me, that leaves the impression the hospital is milking Medicare.
Those charges are that charge master I was talking about. I think you'll probably find that what the payor actually paid was like $2,000. But billing errors are a big thing. My dad had a pacemaker in the week before he died. They didn't get it adjusted right, I guess, and that resulted in his death. And we were billed twice for the pacemaker. And they wouldn't hear it, and they took, and now my mother's a widow, and she was in no great shape, and they took her to collection. And so she paid. This is not the best system. We could have a better system in America. We have a model for a better system in America. Our food distribution system, which has the same requirements for quality and the rest of it, works pretty well. Food distribution works pretty well. Our medical system is problematic, and we can do better. Joseph?
In one of your earliest PowerPoint slides, if I heard you right, you said if you're on Medicare alone, not Medicare Advantage, not much will change for you, but the cost may go up. It wasn't clear to me whether you meant the cost for the patient may go up, or the cost to the Social Security Administration and therefore to the taxpayers may go up.
Well, under Medicare, the Part A part is paid by that tax which you pay over your working lifetime. So the working people are subsidizing the retirees.
So costs may increase. You mean cost to the Social Security Administration, not to the...
Okay. We also, under Medicare, and you're not eligible yet, so you may not know this, pay a Part B premium. The Part B is for the doctor's part. Part A is called hospital insurance. Part B is supposedly to cover the physician costs. And that premium has been going up substantially. And for people with a certain income level, they just artificially double the amount. And so for people in this room, every year they get a COLI, a cost of living adjustment in their Social Security. The increase in the Medicare premium, which is deducted from this, is more than the increase. So their Social Security income every year is going down. And I can assure you that most of the people in this room are aware of that effect and know what that cost will continue to go up. Part C of Medicare is the Medicare Advantage plans that we've talked about. Part D is the prescription drug coverage. Now, Arnie.
A doctor I know is in the practice with about 6 other doctors, and he has 1,200 patients. And he said he can't really do his job on 1,200 patients the way he wants to work by medical advice. He can't visit them in the hospital, all that sort of stuff. Can't take calls all night. He wants to reduce that. And he's linking up with an outfit in Florida called MD something, 3 other letters to it.
MDVIP.
That's it. That's right. And
I have experience with that.
And
don't trust them.
Anyhow, if you want to stay with his practice as he reduces his patient load, it costs $1,800 a year. I would like to hear your experience with it.
That's called concierge care.
Repeat the question. Could you?
Okay, the question is this. He has a doctor who feels his patient load is too heavy for him to adequately serve the number of patients that he has. So he's going into a program that offers concierge care. You know, they give you an annual physical, they give you a little fob with your medical history, they have little things like that. And in addition to the insurance reimbursement, you pay an additional $1,800 a year to have that. And when you go, he'll spend time with you. He can cut his patient load from 1,200 down to, say, 650. And so he has more time, and he can spend more time with you. So it means that he caters to a wealthier clientele. There are a couple of aspects to it. One is by starting our system with the doctors. When you go in, you go to the doctor. That would be like saying, when I go to the supermarket, I don't want to be served by a clerk. I want the store manager personally to take care of everything for me. We start with the highest paid person in the system, and rather than going the other way around. So that's one of the things. But the other is that we've over-specialized, because now you get referred out then to specialists, and many people in this room probably have 5 or 6, 7 specialists they go to regularly. Once you go to a specialist, he says, I want to see you every 6 months or every quarter, because now he's got an annuity income. You come in every quarter, and he's got an annuity income. So that's much. The concierge idea is not a bad idea. When healthcare first started in the county where I live, which is North County, San Diego, they hired a doctor named Kuhn. He was subscribed by the 5 wealthiest families in the county. They wanted to have a doctor there. This is the way clergymen were once recruited to serve a congregation. The wealthy people underwrote the income of the doctor, and then the doctor served the poor people for whatever they could bring. If they brought a dozen eggs, that was great. If they brought a chicken, that was great. And that was not a bad system, and it worked pretty well in a simpler era. Now we're in a little more complicated era. My experience with MDIP, they gave me what passed for a physical. I never got the fob that they promised. I wrote to the people in Florida saying, hey, why am I not getting this? They don't answer. And after a year, I opted out and decided to go into Kaiser. And I've had excellent care from Kaiser. Kaiser doctors have a burden of $1,800, but they have an awful lot of support that seems to make it work. So there are ways of restructuring the system, but just be wary of those folks. Back there.
I have one question for you, and that's about the pacemaker. If
Pardon?
you keel over and your heart stops a certain amount of seconds a minute, you do not have to pay for a pacemaker. So, pretend you're still dead.
Okay, now John, I forgot John. I had too many stacked in my memory
A
right
couple
now.
observations, but maybe some information, you can correct me if I'm wrong. As it's been explained to me, if the doctor treats me for facial, he he or she quotes $1,000. As Jack said, probably collect $12.18. The reason that is, as I've been led to believe, that if I come in with a tattered, torn coat, they can't charge me $25 because the law says that you've got to charge every patient the same amount. And if they charge me $25, they can't charge the guy who's wearing a better coat $1,000 and collect $35. So anyway, a couple things as we've discussed the Affordable Care Act that I think it helps to keep in mind. It was 1935 when Social Security was passed. The first 2 or 3 years were tough years. It was a massive program, which some people think today is maybe the best run government program. It's not something they kicked in and covered whatever the population of the United States was at that point, a lot less than today. There were a lot of hiccups. Something that's, I think, analogous. In the 60s or the 70s, when Congress worked a little bit, they passed a tax law about every 5 years. Every year, and the tax laws were like the Affordable Care Act. It was 2,400 pages or something of the sort. Nobody understood it. They passed it. The following year or 2 years, Congress would pass a law correcting what the IRS in administering the law, and that's got to happen with the Affordable Care Act. I mean, this was 22,000 pages or something. Again, I suspect nobody in Congress, very few people in Congress, if any of them, read it. They passed it. There's got to be hiccups. They're trying to cover 300 million people, and I think it would be, unfortunately, Jack is completely right about the political situation. And just a quote, our son is an orthopedist. As Jack described the CMS, our son said, people are saying, oh, the Affordable Care Act, the government's going to run the healthcare system. They've been running the healthcare system because of the CMS for a lot of years. And that's reality, I think, we need to recognize.
Well, there are a couple of thoughts. One, liberal Republicans, if there is such a thing anymore, progressive Republicans, recently came up with some tweaks that might be made to Obama. They were willing to embrace this law and try to make it workable, and they haven't. There's stuff going on both sides. I forgot. What was the last point you made?
Under CMS, the government in effect.
Oh yes. Okay, that began. I know what I wanted to say. For example, that goes back to the enactment of Medicare and Medicaid in 1965, and that's what's set up the plan system. Before that, we had a very different system. You all remember that. We bought Blue Cross and Blue Shield. These plans went together, and that had come out of the Depression when the hospitals wanted to get paid before people got sick because they lost their jobs when they got sick, so they started Blue Cross so they could get paid. And one of the outcomes of that was that they decided one of the cost savings. The 1965 law was going to cut our cost of health care. We've been cutting the cost of health care all these years while it's been escalating. And one of the things was going to be, we were going to get people out of the hospital and into skilled nursing centers, into skilled nursing. And so there was no such thing as skilled nursing before that, and that's why our care centers today, which are the outgrowth of that Medicare law of 1965, look a lot like a hospital. You know, you have the A-B room where you're at the end of your days, you share your room with a stranger in the next room. And we had a fellow in our apartment, in our community recently. He was a physician, an old-time family physician. He had delivered 3,600 babies. They had honored him in his retirement. You wouldn't believe how this man was beloved in the city of Riverside where he had practiced. And he had been in assisted living, and they moved him up to the care center. And he looked around the room, and I happened to be there at the time. He looked over at this stranger in the next room who was raving a little bit. The fellow was obviously early dementia and was raving a bit. And he said to the nurse, "Is this to be my home now?" And she said, "Well, sir, you know, fluorescent lights, the whole deal." And she said, "Well, sir, they can no longer care for you fully in assisted living. Your needs have progressed to the point where you need to be here." He said, "Well, I'm a physician. I know what to do." He stopped eating and drinking. He was gone in 4 days. It took 4 days. It's a very peaceful passing. You just stop drinking water. And we've had several people now who are choosing that as an alternative to being in those A-B rooms, which are a product of CMS. And now, you mentioned Social Security. I want to say a word about that. Francis Perkins, the Secretary of Labor, led the original Social Security system was predicated on the idea that each generation would have participate in a government savings program to provide for its own retirement. So there would be no intergenerational inequity. And the law specified the actuarial assumptions and how those monies would be invested in treasuries. And the mortality and the interest rate are in the 1935 law. In 1939, people said, well, why don't we just pay out these savings that we're collecting, these reserves, to the current generation who didn't pay in, because that'll be a stimulus under Keynesian economics to the economy. So we switched in 1939, effective in 1940. The first checks went out to the people who hadn't paid in 1940. And people love to receive money. They don't like to pay. So the result is that today's generation, now beginning to retire, the baby boomers, and they understand this, believe me, would be much better off if they had taken their money and bought a simple, guaranteed annuity contract from an insurance company. You don't have to go to private accounts or anything else. They just have the benefit of the interest earnings on their money, because the reserves, Lyndon Johnson, you may recall, also in, I think, 1964 or 5, changed the government accounting so that the trust funds were no longer sacrosanct, but were subject to be spent for welfare, whatever you want to spend them for. So the integrity, and government is not accountable. Government has sovereign immunity. That goes back to the era of absolutism, the absolute right of kings, the rule by divine right. The government has sovereign immunity. If the government breaks a contract, there's no recourse, unless the courts allow you to litigate. And the courts explicitly do not allow litigation in the case of Medicare and Medicaid cases.
We get about 2 or 3 more minutes. So are there any other questions of Artie? This has absolutely been fascinating.
I got one simplistic question as an intermediate step. What if NACRA got a law passed amending the current legislation, which said there's no further distinction between admission and observation in hospitals, and hospitals will no longer be penalized if they readmit someone?
That's already in the works, and we don't have to do that. But for NACRA to have clout, we need to follow one of the guiding principles that our new president, Dan Seeger, has enunciated. We now have 1,200 individual members. In Connecticut, we have relatively few, because you have this free ride system where you just join the community, the whole community sings. And so we can't say, well, we represent all these people who are due to this, so I may pay dues. Well, so that becomes a problem. We need to reach the 600,000. If we get up to even 50,000 people, we'll be listened to. But at 1,200 people, we can argue on the merits, but we do that as individuals, not as an organization. I'd rather work within the scope of an organization. But we have our work cut out for it. Now, in medical care, remember the old mom and pop shops when we were kids? You went to the butcher for your meat, the baker for your bread and baked goods, and the dry goods store and the grocery store, and sometimes you called in and they delivered it, and that was replaced by supermarkets. And that went through seamlessly without a whole lot of flack. We prevent that in the medical care area. We prevent the natural advance that would be possible with the ingenuity of our people. So you can have a centrally planned system, as you've got in places like the UK, or you can have a private system that works pretty well like you have in Germany. There are different ways to do it. But we really need to come to grips with this problem. What we're doing isn't working.
Thank you so much, Jack.